Welcome to the Natera Academy Short Takes series on genetic carrier screening. Natera Academy Short Takes are brief educational sessions to review helpful facts and information for the benefit of our healthcare providers. My name is Erin Armenti. I am a certified genetic counselor and part of Natera's medical science liaison team. In this short take, we will review why and when to offer genetic carrier screening. The world of genetic testing and carrier screening in particular is rapidly evolving in a lot of exciting ways. However, with technology improvements come many questions. Today is the first of several modules discussing various aspects of carrier screening. Today we will be talking about when carrier screening should be used and why it is important. Carrier screening is a form of genetic testing that identifies couples at risk to have a child affected with an autosomal recessive or X-linked disorder. Autosomal recessive disorders are inherited in such a way that a person must have a mutation in each of their 2 copies of the gene in question to be affected with the disease. Individuals with 1 copy of a mutation and 1 working copy of the gene are considered carriers. Carriers generally do not have symptoms of the disease, but if both parents are carriers of the disease, they have a 25% chance to have a child affected with that condition. X-linked disorders involve genes located on the X chromosome and therefore generally affect males, while females are often asymptomatic carriers. A female carrier of an X-linked disease has a 50% chance of having an affected son or a carrier daughter. How frequent are recessive and X-linked mutations exactly? Everyone is thought to be a carrier of at least 4 to 6 mutations for autosomal recessive conditions. Because we typically only see people affected with these conditions when 2 carriers have children, most carriers do not have a family history of the disease. Carrier screening helps us assess risks that a couple likely was not aware of prior to testing. The approaches to carrier screening have evolved significantly over the years. This evolution is reflected in guidelines from various societies, such as ACOG and ACMG. As you can see here, carrier screening is not a new concept. To the contrary, it has been around for decades, but both our understanding of genetic contributions to disease as well as the technologies to detect these genetic changes has improved significantly since the first test for Tay-Sachs disease was offered so many years ago. Tay-Sachs disease is actually a great example of the original incarnation of carrier screening, which was ethnicity-based. While we know everyone carries a certain number of disease-causing mutations, we know that some diseases are more common in individuals of certain ethnic backgrounds, such as Tay-Sachs disease in individuals of Ashkenazi Jewish ancestry, alpha thalassemia in individuals of Asian ancestry, or beta thalassemia in individuals of Mediterranean ancestry. Ethnicity-based carrier screening entails screening individuals only for conditions that are common in those of their ethnic background. However, if carrier screening is only conducted based on ethnicity, you wind up missing many carriers, as demonstrated here with a few of the diseases we already discussed. So, for example, if you only screened individuals with reported Ashkenazi Jewish ancestry for Tay-Sachs disease, you would wind up missing over 75% of carriers. It's also important to keep in mind that many people are not just one ethnicity, and many people may not be able to accurately report or even know all of their ethnicities. The second approach to carrier screening is called pan-ethnic carrier screening, which involves screening all patients for the recommended conditions, regardless of ethnicity. And with the advances of genetic testing technologies to allow us to screen for many conditions at the same time using a relatively small sample of blood or saliva from the patient, expanded carrier screening allows us to simultaneously screen patients for a large number of conditions. And some of the more recent ACOG committee opinions really reflect some of the limitations of ethnicity-based carrier screening and recommend more broad screening for some conditions, specifically mentioning hemoglobinopathies and spinal muscular atrophy. When we look at the data from these large expanded carrier screening panels, what we find is that across ethnicities, about 2.3% of couples are identified as carriers of the same recessive genetic disease and are therefore at risk to have a child affected with that condition. If you think about the number of patients you see in your practice in a given month or even a given week, what this means is that we're all encountering these at-risk couples more than we realize, which is part of the reason why carrier screening is so important. I'd like to talk next about the various windows of time when carrier screening can be performed. It's important to keep in mind that carrier screening can really be performed at any time. It is a DNA-based test, and our DNA doesn't change. So this is different than something like MSAFP that needs to be done at a certain window in a pregnancy. However, there are three main groupings of time relative to a pregnancy when carrier screening can be performed. Carrier screening can be performed preconception, typically when a couple is considering a pregnancy. And according to ACOG, this is the ideal time to offer carrier screening. We often see this occur in the assisted reproductive technology world, where carrier screening is part of the initial workup in a lot of fertility clinics. However, we can also see this happening in the OB office, especially in a situation where a patient does have a family history of a genetic disease. ACOG maintains that carrier screening should be offered early and offered to everyone, stating information about genetic carrier screening should be provided to every pregnant woman, and carrier screening and counseling ideally should be performed before pregnancy. Most people experience carrier screening in the context of a current pregnancy. Carrier screening is traditionally done early in pregnancy, which leaves the patient more options for diagnosis and management of the pregnancy should the couple be found to carry mutations in the same gene. It is important to keep in mind that carrier screening can also be performed after delivery. We'll talk more about carrier screening as it relates to newborn screening in another module, but for now, it's important to keep in mind that while carrier screening after delivery can certainly provide more information for the couple and their child, the situation is different than the other two timeframes we discussed because there is typically already a suspected genetic diagnosis. I'd like to spend the rest of our time with this module talking about why carrier screening is important. Oftentimes, when you bring up carrier screening to a patient, especially in the prenatal context, you may be met with resistance because a patient doesn't think that information will change anything about how they would manage their pregnancy, when in fact, there are many other reasons why carrier screening can be important, actionable information for patients. That being said, patients who undergo preconception carrier screening tend to have the most options available to them, simply based on timing. Some couples learn that they are at risk to have a child with a genetic disease and may choose child-free living or alternative options to building a family, such as adoption or gamete donation. Other patients opt to proceed with spontaneous conception with or without diagnostic testing during pregnancy, with the idea that the information they received via carrier screening prepared them for the possible outcomes. Lastly, some couples choose to undergo IVF with pre-implantation genetic testing, where embryos are screened for the mutation or mutations identified in the couple. When you talk to patients, they demonstrate time and time again that this information is actionable to them. When surveyed, the majority of at-risk couples were planning to use their carrier screening results in some of the ways we discussed on the previous slide. When couples undergo prenatal carrier screening and learn they are at risk to have a child with a recessive genetic disorder during pregnancy, they may opt to pursue diagnostic testing such as a CVS or amniocentesis to clarify the risk for that pregnancy. This is where the timing of screening and whether a couple is screened in a stepwise or simultaneous manner become important, since CVS and amniocentesis can only be done during certain windows of pregnancies. For some conditions, targeted ultrasound may inform the genetic risk, though ultrasounds are not diagnostic. If a carrier couple opts to pursue diagnostic testing, there are a large variety of ways the couple may choose to use that information, including pregnancy management options and preparing for the birth of a child with special needs. This can range from educating themselves about the disease and treatments available, to identifying a team of specialists to care for the child, to setting up an alternative delivery plan to ensure that the child has appropriate care in the neonatal period. Many parents also use this time to identify a support network and connect with other parents of children with the disease. In fact, though no patient is ever excited about the prospect of diagnostic testing, the majority of at-risk couples screened during pregnancy do plan to pursue CVS or amniocentesis. This quote from the mom of a child with spinal muscular atrophy is particularly powerful because it reflects what a lot of parents of children with genetic disease will tell you when you ask them about their experience. I painted her nursery. I bought her clothes. I went to all the classes to learn how to swallow her, but I didn't get the chance to research, connect with other SMA families, educate my family, meet the doctors that would keep my baby alive, save money for the medical bills, the wheelchair accessible home and car we would need. These are all the things that I would do differently had we known. And just as the world of testing for genetic diseases is changing in new and exciting ways, there are also new treatments for a lot of these diseases that are drastically altering the course of the disease for many affected individuals. There are a few examples listed on this slide, and they come with some really powerful stories about how these new medications are positively impacting lives. Carrier testing after delivery doesn't have the same options for risk management compared to the other time windows for carrier screening we've discussed, but should not be ignored. Genetic testing can help a family achieve a diagnosis on a quicker timeline, which reduces the emotional impact of what many parents refer to as the diagnostic odyssey, or the seemingly endless battery of doctor's visits and tests trying to identify the cause of a child's symptoms. Carrier testing after delivery may also give the child earlier access to important treatments, like the ones we've just discussed, which is typically linked to better outcomes. Lastly, the timelines we've been discussing become cyclical in that many couples are planning to continue to grow their families, and the information obtained during carrier screening gives them many of the options we've discussed for future pregnancies. This is highlighted in an ACOG committee opinion from a few years ago and is echoed in how genetic counselors counsel patients every day. There is no right or wrong way to move forward with carrier testing and subsequent decisions. Carrier screening is really about empowering patients with information to make the best decision for their family.